A very warm welcome to you and thank you for joining us on Health and Wellness. My name is Zaitun Ali and I'm so glad to bring to you this very season that comes live to you from studio, and feel free to interact with us on our social media handles at KTN Home, at Ali_Zaitun, and also we have a WhatsApp line 0759-434389. In case you have any questions, feel free to drop a comment, ask us anything, and today's topic is going to be about endometriosis. First things first, we just want to put our condolences and tell the family and friends of Jambi Koikai. We're very sorry about what happened. She was a mentor, an amazing activist for social justice, and she was also an endo warrior. And out of this, we just want to create more awareness on this show. So before I introduce my guests, first things first, let's check fact of the day. Has enormous implications on the quality of a woman's life. This severe inflammatory condition occurring in 5 to 10% of women of reproductive age. Now that accounts to 190 million globally. It can cause constant and intense pelvic pain, fatigue, depression, anxiety, and fertility. So that is the fact of the day for endometriosis. And right now, I want to introduce my guests. I'm so happy that I'm joined by Dr. Yamal Patel. I said it right?
Yes, please.
He is a laparoscopy surgeon and an endometriosis specialist. Karibu sana. Good to have you on the show. We also have a Sylvia Savai, aka Senje Comedy. Yes, and she's a content creator and also an endo warrior. Welcome to the show.
Thank you.
Dr. And definitely I'd like to start with you just to create more awareness. Talk about endometriosis. What is this condition?
So where do I even start? Endometriosis is a very complex condition to describe.
Yeah.
In simple words, it is when endometrial lining-like tissue is growing outside the uterine cavity. So it could be anywhere outside. But in full definition, I like describing it as something that is chronic, that is inflammatory, has fibrotic issues, is hormone dependent, is something that has debilitating effect on quality of life, both physical, psychological, emotional. It actually does, it is a disease that is poorly understood and often misdiagnosed, and a disease that doesn't have an exact cause. It's a disease of theories, and it therefore is something that really has major impact on the quality of life of a woman.
Okay, that makes sense. Very complex, but I know, Senje, you've gone through this condition.
Yeah.
Probably just talk about when you realized that this was endometriosis. What kind of symptoms were you showing?
Okay, all along I knew that I had PCOS according to the doctors I used to see before.
Okay.
But then last year in September, it's when I was diagnosed, and the doctor said that I have been ailing from endo, but I didn't know it was endometriosis. So the signs that I had were abdominal pain. I paralyze on my right side of the body when I'm on my periods. I black out from time to time. There's back pain, there's diarrhea, there's fever. So the whole thing comes at once and it attacks you and it's so painful.
Okay. Yeah. And according to what Senje is saying, Dr. Does it mean PCOS occurs with the same symptoms just as endometriosis?
No. The PCOS is a condition that is a hormone imbalance condition.
In full?
And hormonal imbalance, polycystic ovarian syndrome.
Okay.
It has hormone imbalance impact, so mainly impacting regularity of the cycle, sometimes weight gain, sometimes acne and some other androgenic features, excessive hair on the body, and impact on fertility. But it is also hormone dependent.
Okay.
It has an excess of estrogen. And in that aspect, endometriosis is also hormone dependent. That is worsened by the estrogen hormone. So in that way, they can be together, but they are not exactly presenting the same way. The pain component is not seen in PCOS. The pain component diverts the diagnosis more towards endometriosis.
Okay. And when did you start feeling the symptoms? Probably was it when you first had your periods, or when was that?
Yeah, it was when I started my period. That was in 2004 when I was in primary school.
How old were you?
I think 13 or 14.
Okay.
So it was a very weird thing to happen because I didn't know what exactly that was. So my mom has not gone through this. So going back home, mom didn't understand what exactly was happening to me. So I had to explain. I just started my period, and the kind of pain I'm feeling, I've never felt that before. So when time went by, I realized that I had started growing a beard. So that was a very awkward situation to be in. You know, when you're in school and then you're seated with someone and then they're staring at you like, when ni msichana kwa nini uko na ndevu?
They were that much. They were like
here.
Oh,
so
in the neck.
Yeah. So back in the day, I used to walk like this because I used to hide it a lot. And then when time went by, I came to realize it is not my fault. It is what I'm going through.
Yeah.
That is what is creating whatever is happening on my chin. So, yeah, let's just say
around 13 years.
Yeah, around
and
13
how
years.
it presented itself, it was a lot of pain.
Yeah.
And then later on, it's every single month. That's how
every
it
single
was.
month. And every single month it worsens. The kind of pain I had last month, it's not compared to the one that I have next month. So next month I always know that it's gonna be much than whatever I experienced last month.
Okay.
Yeah.
And Dr. talking about now misdiagnosis, because those symptoms are really very severe. For one to be misdiagnosed for all those years, it brings now a question mark. So how do we diagnose this condition?
Well, I mean, you see, I told you it is a very complex disease that sometimes has similar presentations to many other things. So we have primary dysmenorrhea, which is also pain during periods, but not necessarily due to a cause, and it's due to excessive production of inflammatory markers in the body around the time of the periods. And then there is secondary dysmenorrhea, which is due to some causes. Endometriosis is one of them. A polyp could be another one. Adenomyosis is another one. Some fibroids in certain locations could also cause pain. So basically speaking, when we're looking at just painful periods as one, it is one of the causes which could be there, but it needs to be ruled out rather than assuming and normalizing pain. That's one thing that is definitely a wrong thing to do. Don't normalize pain. Have it checked out, and then let us then say that this is due to this. So I think that's very important, because you may see in our growing up, when a girl starts getting periods and start crying and does not want to go and play when she has periods, she has a social event booked, and then she says, I can't come, it's suddenly, so your friends back off, your relatives back off, your school doesn't support you, they make fun of you, your workplace makes fun of you, saying that, oh, you see, next week I think this woman is not going to come. She's going to miss school work for 2 days. You know, she's used to this.
Because it's like an excuse.
So that becomes a problem, right? So it has that impact that is very far and wide. So diagnosis is clinical and suspicion, and then a proper examination and evaluation by imaging would be the way to go.
Okay, by imaging.
Oh, yes.
Okay.
I mean, if done well and by endometriosis specialist, I think it's very straightforward to pick it up.
How was your diagnosis looking like? Because I know you had questions. What caused this? What am I experiencing? And probably even Doc can come and tell us perhaps the causes of this, but how was your diagnosis process?
So this one time I was at home. So my period started as normal. But then the paralyzing situation worsened. It was bad. Like in September, it was worse. I hadn't experienced that the way I experienced in September. So I go to the hospital. My friends come, takes me to the hospital. They've never seen someone in that condition. So when we are going there, they're worried, and then they are like, do you go through this every month? Is this how you're always? And I'm like, yes, this is how my period comes. So we get to the hospital, I get the injection, we go back home. So I decide, let me go to another hospital. So I start going to Aga Khan. So I go to Aga Khan, I see Dr. Patel, and then he checks up on me, and then he's like, do you have kids? And I say, Sina. And then he goes like, do you want kids? And then I said, yes, I want kids. And then he goes like, oh my God. So I'm stuck in bed, and then he's looking at me like, if you had kids, I think we would have done away with the, what is it called? The uterus. Yes. And I'm like, no, I want kids. So he says, come, let's have a conversation. And then I walk him through my journey. So the moment I told him that anytime I get my period, I paralyze on my right, he was like, I have never heard of that. I have never heard of anyone paralyzing. But I have seen girls go through that pain, complaining about their abdomen and that. But the paralyzing situation, that's a new one. And now he says, according to his, whatever it is that they were inserting, it showed that my right ovary is stuck behind my uterus. My left ovary is eaten up by endo. My appendix is not looking good. So we sit down and we have a conversation, and then these tests are carried to third pack. Yeah. Okay. So I had to take the all that thing back there so that they can go through it. So he calls me again, I think in 3 days' time, and I go back, and he's like, your situation doesn't look good. And because I had told him that I black out from time to time, and it really takes me by surprise. So I don't even go outside anymore. I don't use matatus anymore.
So were the blackouts when you were experiencing your periods alone, or just any time?
No, so now the paralyzing and the blackouts used to happen when I'm on my periods. But now they happen anytime. Like it can attack me like right now, anywhere, any place. Sometimes I wake up in the morning and my right side is not functioning, and I'm stuck in bed. So when I went there, he was like we had a conversation again, and he said, I might be able to get rid of the endo, but the paralyzing part, I am 100% sure that is something we need treatment outside, like you say abroad, because the hospital that was treating Jambi is the same hospital that I was referred to, and he is the same doctor that was treating Jambi all through. So I think those other side effects that I was experiencing
was a result.
Yeah, like they made my condition worse. And it's something that has not happened. So he was so worried. So now when I started talking to the hospital in Atlanta, they said my condition is bad. They've had patients with similar conditions, but mine, the way I'm explaining, like now the paralyzing thing has overtaken, like it comes through to my face. So it's an emergency. Because they know doctors in Kenya who can treat endo, but now this is a new case. So I'm explaining to them, and then I've lost 4 teeth. I didn't even know endo can cause cavity.
And let me even engage the doctor on this. As you're listening to what she's talking about, probably first let us know what causes this kind of symptoms, what causes endo, and also just break it down for us, whatever she's saying, the symptoms which she has been.
So endometriosis is something that is not having an exact cause. So it has many theories as to why it happens. Just to name a few, there's something called retrograde menstruation. So when you have periods, when the blood is coming out, some blood could go backwards through the tubes into the pelvis, and that happens all the time to every girl. So, but not everyone gets endo. So there are some situations where we can explain that this fluid has some endometrial-like tissue and it's growing outside, and then it starts growing in different parts of the body. But then there are other theories like tissue injury and repair. There's something called epigenetic theory. So it has many theories that can be used in explaining a certain scenario, but not as another scenario. Now, what it does eventually is these lesions start growing outside the uterus. I told you it could be the tubes, the ovaries, somewhere behind the uterus, in the bowel, in the bladder, in the diaphragm, in the lung. It has basically been seen everywhere. I've seen one in the eye, all right, in the nails. So it can be anywhere, all right. In the brain, there are people who sometimes get convulsions every period they get. So it's not a fun disease to have.
Yeah.
So basically speaking, it can also therefore grow and infiltrate. Now there are three varieties. There is the superficial lesions, that's called superficial peritoneal disease. There is deep infiltrative endometriosis, which is the worst of the kind, and in deep infiltrative endometriosis it infiltrates into surrounding structures like cancer, but it's not cancer. And I would say cancer surgery might even be sometimes more easier to do than sometimes endometriosis, because it kills all the planes around.
Yeah.
And another thing about endometriosis, therefore, is if it now infiltrates down into the pelvic nerves, now that's when something like this can happen. So you see, these nerves all are exiting from the body into the legs. So if they infiltrate into a nerve, it will now cause different symptoms based on which nerve is being compressed and pressed on. So if it's pressing on the sciatic nerve, you'll have this sciatic-like pain in the back and the legs. If it compresses the pudendal nerve, it causes different symptoms. So from what you seem to be experiencing, I think maybe some nerve may be infiltrated or compressed by a nodule that is sitting somewhere in that pelvis of hers.
Oh no.
Yeah, I mean, just yesterday I've operated on a patient actually who had it infiltrating into the ureter, and she's basically losing a kidney, right? So it causes blocking of the ureters, and now it has caused the kidney to swell up and now lose function. It was probably at 30% functionality when we assessed it. So we had to release this nodule, the ureter, from the nodule around, which is extremely difficult. But then that's the only way to save that kidney now.
And now, like Senje is saying, you lost your tooth. Your teeth.
My teeth.
And then also you mentioned about the appendix.
Yes, so appendix is bowel. All right,
bowel.
so it could be bowel in the rectum, it could be bowel in small intestines, the appendix, the cecum, any bowel.
What
but
about the
appendix
teeth now?
is very common. Teeth is one of the rare things. So I don't know, I mean, if they have confirmed it to be endometriosis related, but if they have, then yes, it's one of the things. I told you it can be anywhere. We've seen very funny locations of endometriosis. But that's one of a very rare,
And
probably kind.
You see the normal toothache. Now this one is like 10 times.
Yeah.
It's bad, like it picks the whole, like if I have a tooth that is aching on the right, so this whole right side is in pain. My ear, my neck, like the whole side is in pain. So it's crazy.
Oh God. And I want us to even come now to the risk factors that she's talking about, because the first thing the doctor asked her was, would you like to have a child? Yeah, so...
Well, that's not a risk factor. And again, I mean, I can categorically say, listen, once diagnosed with endo, please don't take it as a death sentence, and don't take it as a condition that means you will now not have children. No, I mean, I believe every woman with endometriosis should have children. It's only that it might be difficult. It may need some assistance. It may need some correction. It may need some artificial reproductive medication, I mean, treatments like IVF. We don't know, but it's possible.
It is possible.
So, and another myth out there that I would like to dispel is pregnancy does not cure endometriosis. So, you know, some people are told, they're told, please go get pregnant quickly, you'll probably...
the period pains will subside.
But the fact is, the hormonal situation around pregnancy will improve the symptoms and will reduce and slow down the endometriosis during the pregnancy period. But then after delivery, it will again restart regrowing because your hormonal situation again improves. So basically speaking, it's not a treatment, and it should not therefore be given as an option that, please, my advice, go get pregnant quickly. I mean, no, it's not the way to do it. So I think what we are trying to say is pregnancy improves the symptoms. It may be difficult to get, but it's not impossible to get. It only needs to be planned properly.
Like on my case, I've had 2 miscarriages. So I've always known that it's the condition that I have that is causing the miscarriages. But I always think positively, like I might, after the treatment, I might get pregnant and carry it to term. Is that possible?
You will.
I will.
So don't be
That's a
negative.
good one.
You will. But
a
the
good one.
issue is, as I've said, I mean, endometriosis directly does not have major impact on the pregnancy outcome as much as another condition that it is always associated with called adenomyosis. Adenomyosis and endometriosis are similar in one way, that in both of them, endometrium-like tissue is growing in a place where it's not supposed to be. In endo, it's outside the uterus.
Yeah.
In adenomyosis, it is in the muscle, in the wall of the uterus. Now, adenomyosis definitely has all those impact, including miscarriage risks, risks of implantation failure and fertility issues, preterm labors, you know, all those other complications. And pregnancy in adenomyosis is a high-risk condition. So many times these are associated with each other, and I think with full evaluation of your condition, we might be able to tell you also if we can answer why that happened, if it is related or not, because there are other causes as well that need to be ruled out, but that's a possibility.
Yeah.
Okay?
Okay.
Okay. It's good to hear the journey to your diagnosis. At least we've had the symptoms, and we just want to take a short commercial break, and when we come back, we'll come with more about endometriosis. Now we'll jump into the treatment processes. What options do we have? But again, thank you so much for giving us hope. It is possible to carry your baby to term. Mtu asikwambie endometriosis you can't deliver, so you can. So stay tuned. Remember to send in your questions on your WhatsApp, on our WhatsApp 0759434389, and also on our social media handles at KTN Home. If you have any question, any comment, we have our guests still here in studio. Don't touch that dial. Welcome back. If you're just joining us, remember this is Health and Wellness. My name is Zaitun Ali. Thank you for staying tuned. We are live in studio right now, and the topic of discussion has been endometriosis. So right here in studio, I still have Dr. Patel.
Yes.
He is a laparoscopy surgeon and an endo specialist, together with Sylvia Savai, who is an endo warrior as well, and also a content creator. Check her out on Instagram. A very, very funny human being. Karibu sana. And before the break, we were talking about diagnostic processes and just how to check the symptoms. And also Sylvia has shared her story as well. Now, coming back after the break, what I want us to dwell on is the treatment and management processes. Let's start with the treatment processes. What options do we have, Dr.?
So, treatment, before I go into exact details about it, number one, we would say starts with a proper diagnosis. So diagnosis is not enough to tell somebody you have endo. In today's world, diagnosis is not enough to be done by laparoscopy. That's what has been happening in the past, that I think you have endo, let's go confirm it with a scopy. I think it's gone beyond that now. Okay. We can very specifically identify and classify endometriosis in a woman after doing the examination and a detailed targeted ultrasound for endometriosis, which is a very specific process, and I think requires a very high level of skill and training to do that. But I think it's very possible to now identify with a transvaginal scan or a transrectal scan for that matter, and sometimes an MRI of the pelvis. So starting off, first classify and diagnose the disease. Once you know you have the disease and what extent of the disease you have, then you come to management.
Okay.
Now management...
And even before you go to the management, there's something Senji had mentioned that when they did a test on her, I don't know which of the tests was that actually showed that her uterus lining looks like this and that. Probably, was that the right diagnosis?
That's the ultrasound. No,
Ultra.
It's not the targeted scan.
Okay.
That's what I'm trying to explain. I mean, the targeted scan looks at, let's say, almost 10, 15 different areas.
Okay.
And will tell you, in this area you have this, in that area you have that. So it's very different. And I think now here in Kenya, in Nairobi, we do that. All right? So we need a targeted scan, not just a scan. So these are two very different things.
Okay.
And then we classify the disease. And now, with that classification, if we don't and we just say you have endo, you go in, you remove whatever you see big, and you leave the symptoms. I mean, one of the things you might have heard so many endo warriors say, is we've had repeated surgeries.
Yeah.
All right?
Yeah.
Take Jambi Kokai forever. I mean, for example, 21 surgeries, not acceptable. All right? This is what I'm trying to explain. That this is because not any given time probably was the full evaluation of the extent of the disease probably made. And if you make that, then you know exactly what needs to be done in which part of the body and to remove which nodule from which area. If we don't do that, basically we leave residual disease behind, and many times it keeps on causing the symptoms. So you'll see people who would have surgery and then in 2 months after that they are still in similar scenario, and you can't explain what's happening. So these repeated surgeries is not supposed to be allowed. I mean, ideally identify, classify, and then stratify the disease, and then handle it with an endo specialist and a multidisciplinary team with an endo center to get rid of the disease properly.
There's actually someone who sent in a message. Hi, I'm a patient of endo, stage 4, and adenomyosis without children, always in pain. What advice can you give? 4 surgeries done.
So this is what I was trying to tell you. So this is telling me that this woman has extensive disease, and it is both in the pelvis outside the uterus and in the uterus. So she'll again need the same detailed targeted evaluation before planning out the procedure, if at all needed. And then I think with that, we've had many patients, as I've said, who've managed their quality of life improvement, at least live a normal life. I mean, it's not fun living in pain throughout your life.
That is true.
So live a quality of life, and then if fertility happens to be a goal, then it's called fertility enhancing surgery or reproductive surgery. How do we improve the quality of the pelvis to increase the chances of getting pregnant? Now, whether it will be naturally, depending on whether the tubes and everything is fine, because many times the tubes are damaged badly as well, or whether it will be IVF procedure for doing the fertility, depends on what it is. So my advice, have the detailed evaluation done, then sit down to plan what needs to be done.
Now the treatment.
Yes.
And for Senje, which treatment are you now, do you want to go and seek for, especially abroad?
So according to the doctors, they are supposed to fix my appendix, bowel, and the ovaries. And then they have to look at what exactly is causing me to paralyze.
So Dr. you can advise now, what is the right treatment process at this?
Especially on the paralyzing thing.
Again, I haven't personally been able to evaluate the condition. So I think my first advice, give me a chance. Let me have a look. Let me do the evaluation. Then we sit down and make a plan. But from what we are saying, appendix, bowel, rectum, bladder, diaphragm, lungs, the ovaries, the tubes, this is all possible here in Kenya. And we do them regularly. So, and including the nodules in the parametrium, which now go towards the nerves, possible. So what I'm saying is, give me a chance to assess, and then let's sit down and plan.
We have a lot of feedback coming in. Let me also ask this. Ask Dr. Patel, what are the risks of high CA125 results and enlarged ovaries due to endometriomas?
So endometrioma is now one of the varieties of endometriosis that I was talking about. There's superficial peritoneal, there's ovarian endometriosis, which is the endometrioma. It's a cyst, which is like also called chocolate cyst. And then there's the deep infiltrative, which is now the worst, which infiltrates into surrounding structures and grows big nodules and causes extreme pain. Now, endometrioma, because of its nature, has altered thick blood that is in this cyst of the ovary. And because of that, the CA125 is elevated in these women. So basically, it's not a diagnostic criteria.
What is CA125?
It's a hormone. It's a tumor marker. And this is a tumor marker that is also a tumor marker for ovarian cancer. So you see, most of the times when people have this, they start worrying, oh, am I being, because it's even called cancer antigen 125.
Okay.
All right. So they start thinking, oh, am I having cancer here? No, it's not cancer. It's just an elevated inflammatory marker and tumor marker that is seen in endometriomas. The level increased in endometrioma may be in some hundreds. All right. Okay. Some 70, 80, 100, 200, 300. That's the range. And in cancer of the ovary of a certain kind, that's the epithelial cancers, you'll see it in thousands. So please don't immediately correlate this to cancer just because it reads cancer antigen 125. So it doesn't mean anything, according to me, for her. Tell her to relax. It's due to the endometrioma.
Okay.
Yes.
There's one saying, hi there, watching live from Bomet and touched by your message. Would like to humbly ask the doctor, why is it that every time I engage in sexual activity with my husband, I bleed and been treated UTI, STI and every sort of infections? Is it about endometriosis?
Not exactly. Endometriosis and sexual relation is again around pain. Now, if you have a nodule behind the uterus, and that's in those ligaments behind called the uterosacral, or behind in the middle called the torus, or in the bowel, trust me, that woman is not going to allow you to have sexual intercourse with her.
Okay.
And this has broken many families and many relations. Why? Because it's going to be difficult trying to explain why you're not allowing, a conjugal right to...
I know.
It's difficult. So
it is, for sure.
Pain is what they really have bad with, and it's
Okay.
deep pain inside.
Yeah.
Bleeding could be something very different. Okay, endometriosis does not have relation with bleeding after intercourse. That could be something locally in the cervix, could be an erosion on the cervix, could be a change on the cervix, or due to HPV virus, or it could be something like a growth, like a polyp near the cervix from inside. So every time they have intercourse, she bleeds from this. So she just needs an evaluation, and that is treated differently, but that's not specific for endo.
Okay,
Yeah.
that is fine. Let me take one more before we just continue the conversation. This is a long one. I'm so glad you're talking about endometriosis. I got my periods around the ages of 11, 12, and I had no pain. In fact, I came to know painful periods existed in high school. Apart from the slight discomfort, I was okay through my teenage years. The year I turned 19 is when things got really bad. At first, it was just the pain. I relied heavily on painkillers. Then the nausea hit. I could barely keep any food down. In fact, I would go to a chemist and get a painkiller injection. I hate needles, so to avoid them, I will take lemon tea with painkillers. It helps with the nausea. Over the years, it got worse. The diarrhea and the back pains and followed as well. So is it because of endo?
Again, it needs to be ruled out, definitely.
Yeah.
So her symptoms, again, you heard Sanjay say that every month it would be worse than the other one.
Yes.
So it's a progressive disease, and being progressive makes it, it's growing because it's growing and infiltrating further into the disease, into the other areas. So yes, it needs to be ruled out, but again, that is not enough to say that is endo. But endo is high on the list there.
Okay.
Definitely needs to be ruled out by a proper evaluation. And from her symptoms, it could be in more than one place because she also has vomiting. Sometimes we've seen endometriosis in intestines, small intestines, and the only presentation they have is vomiting every month.
Okay.
And yes, I mean, it could be a problem. If it's a lesion that's growing on the bowel and it's constricting the bowel, again, it will cause problems. So it is something that in her case needs to be definitely looked into. It should not be taken lightly. And if it is, trust me, if you're diagnosed early, you're treated early, and you'll probably have a better quality of life. The moment it goes on beyond a certain limit, again, what she said, what she just said, keeping a keen, my principle is one very important point here. Listen to the patient. They will tell you what's going on.
Okay.
And every single word that she said is already here. When she says, I used to get it during periods first, now it can hit me anytime, including sitting here.
Yeah.
Now that makes it chronic pelvic pain. It becomes CPP. And that is because of sensitization, central sensitization of your body to pain stimulus. It reaches a certain point that even once that area is sensitized, it's in the peritoneum. Even a touch like this will trigger pain to the brain. And there'll be no specific reason why, but it just suddenly hits you. And that is exactly what will happen if you let it go on for too long. The pains that are cyclical will become pains that are chronic. And then you will have also these women have multiple diagnoses. I've been told I have IBS. I've been told I have fibromyalgia. I've been told I am psychiatric. Some people believe this woman is mad up here.
Yeah.
I've been told I'm attention seeking. I've been told I have interstitial bowel syndrome. Bladder syndrome. So basically, you'll now have a multitude of diagnosis, whereas the primary cause is endo, which has so far been missed out.
So that targeted approach is what we are lacking.
The patient I was just talking about yesterday was diagnosed by me for endo 2 weeks ago, and she's lost a kidney because of the endo.
How long has she been suffering?
And she's had multiple symptoms and has been visiting multiple doctors and has a kidney that has developed a swelling and hydronephrosis, whereas the diagnosis has not been made that this is due to endo. Until we've done the detailed targeted scan, and the first thing I said, oops, I think this kidney has hit your ureter and it's affecting your kidney. When we assess the kidney further, we realize she only has 30% of probably the functionality left in that kidney. Not right. If this was picked early, it would never have gotten that bad. And so I think early diagnosis,
a stitch in time saves 9. That's 100%. What they say. Senja, let me ask. The first thing that you mentioned also, I'm also listening to the patient, Daktari, and she mentioned that she was told to do hysterectomy. Yeah, like, would you like to have a baby? So have you had a baby? So the first thing that doctor thought about was just getting rid of the whole uterus. Was this a proper solution?
Treatment for endometriosis is something we say is supposed to be preference based, is supposed to be goal oriented. So if it's supposed to be individualized and tailor made. So there is no one standard treatment. Okay, what I would advise A is not what I would advise B. All right. So if her goal, and she's young, if her goal is fertility, hysterectomy never comes in the treatment plan at all. And let me put it categorically, hysterectomy does not treat endometriosis unless the disease around it with the endometriotic nodules are removed. How many patients have I operated on who've had a hysterectomy done already, but the pains persisted, and that's because the endo was left. Because it's such a bad pelvis, it messes up the whole anatomy of the pelvis, that when the uterus is removed but the endo is left behind, I can trust you, I kid you not, the very next month, not because your periods are gone, but the very next month you are still in pain. So hysterectomy is not a treatment option for endometriosis. It is only going to work if the endo around it is also removed, and it is probably the adenomyosis part that would be cured by removing the uterus. But unless adenomyotic uterus is also removed with the surrounding endo, the pain does not go. The surrounding endo has to go.
And time is not on our side. Probably, I know you had a question for Dr. Risenje. You can ask a question to him, and also just tell people what they need to know about this and just how they can manage it, what you've been going through.
I think I have 2 questions.
Good.
So the first question, when you mentioned that your patient said that they cannot, can I say have sex?
Yes, I mean, because of pain.
It's okay.
Yes.
They cannot have sex due to the pain they have. Personally, I cannot have sex during ovulation. So during ovulation period, I have the same pain I have during my period.
Yes.
So is that treatable? Or what can I do, like, if at all, because I know I have to get pregnant when I'm ovulating, but then I cannot have sex.
So
And
how do you
at
get
that
pregnant?
time.
So that's what I'm saying. So you see, it's a dilemma.
Yeah.
Yes, again, is that solvable? Yes, why not? Get rid of the endometriotic lesions that are around that area that are activated or that are the cause of the pain. And majority of the times I told you that is because of the lesions that are somewhere behind the uterus or in the vagina. They sometimes infiltrate the vagina. So get rid of that and you get rid of the pain and you go back to a normal life, at least conjugally.
Okay.
Okay.
So my other question was, you as a doctor, if you had a patient who has endo, but there's other things happening that you personally, let's say, you can cure 60%, but the 40% you cannot do it. Will you go ahead and cure the 60% and refer them elsewhere, or you'll just go with the 60 and then wait until they're healed and see if the 40% is still there?
Okay, nice question, and I think very important for all of us in the medical field. So let me tell you, I'm a trainer. I teach people. I train minimally invasive surgery and laparoscopy.
Okay.
And one of the questions I say, and that is very pertinent, especially for endo, although it comes with every single disease for that matter, I tell them taking off in a flight is optional. Landing is compulsory.
True.
Yeah.
So meaning, if you take off, but you don't know how to land that plane, then don't take off.
Okay.
Okay? So in simple words, what I'm trying to tell you is, if I feel you have this much disease, but I can treat this much disease of yours, then I shouldn't take off that plane.
Okay.
Unless I'm also certain that I believe I have the ability to land that plane and treat the whole thing.
Okay.
So if you can't, the best option for me would be to refer you to somebody who can.
Okay.
So you get the point. I mean,
get you.
What's the point of then doing half this treatment where you know that it's going to further still remain and cause the problem to this patient?
Yeah.
So I think referral to the right team is key in that aspect.
Thank you.
Thank you so much for that, Daktari. And I know you had told Senje to give you a chance, and I know she will, but you also had a medical appeal that you wanted to tell people about. You were denied a visa.
Yes, I was.
How was that for you?
It was hard because I've never been to the embassy before, so I don't know how it works.
Okay.
But it's very hurtful knowing that you've gone there. Kwanza, what happened was, Jambi died like today. I was supposed to go to the embassy tomorrow. I was so broken because Jambi was like a sister, like a mentor. We always talked. Like whenever I was in pain, I could tell her, "Leo nasikia vibaya, what should I do?
Yeah.
It's worse than yesterday. What should I do?" And Jambi was a very strong person. She was in pain every day, but she was a very strong person because she knew what exactly I was going through.
Yeah.
So going to the embassy, I had cried like the whole night. So I'm going there thinking of her, and then I'm scared. I'm like, ama nitakufa.
Oh, yeah.
You know, because this is your friend, she's going through the same thing with you, and then she leaves, and then now you're stranded. So going there and being denied a medical visa, I feel like it's unfair. I wasn't going there for leisure. I'm going to get treatment.
Yeah.
So if our government, I'm sorry, doctor, I know you're here, but I have to talk about this. If our government is listening, and we cannot, maybe we cannot, I'm sorry again, if we cannot get the right treatment here, or my doctor refers me to a hospital that he's 100% sure I will get the whole treatment that I need, then why deny us visas?
Okay.
We are sick. What if I died today? Then people will go on saying Senje alienda embassy akanyimwa visa, right? And that is going to cause commotion. It's going to be a big deal.
Void,
You see, before Jambi died,
Yeah.
sikwangi mtu wa politics, lakini wacha tu niongee. She wrote a letter to the president talking about endometriosis, how much she has fought, how many women are in her DM trying to get help. but no one answered. No one even shared about that thing.
And
but when she died,
yes,
it was everywhere. Why wait for someone to die so that you can listen?
I hear you.
Yeah.
I hear you. And that will be part of our conversation as well. And I know we haven't had time to finish up, especially the treatment, the advocacy. We will be dwelling on that as well on the second episode next week, still with Dr. Patel. And we will address that. So your appeal, I know Dr. will tell you in Kenya, they can also treat you. It's fine, but you can just mention to people how they can contribute. Before ufikie the target, also you can try doc and see if you can even find an option right here locally. Yeah, you can just tell people.
So I haven't mastered my pay bill.
If I'm seeing it right, is it 6?
Oh yeah.
6, 8?
Yeah.
4, 7. Let me check. Okay. But tell them to just...
So to contribute for my treatment, you can pay through the pay bill, or you can do it through my M-Pesa number 0706 224 983. And to the women out there, if you have a daughter, or you are a wife, a mother, or a sister, if your relative is going through pain, it is the best thing to do is to get them to the hospital to get checked instead of waiting for them to get worse and then you take them to the hospital. But as for me, my family has been there since day one.
Wow.
But
That's
emotionally, they are drained because they've seen me for 20 years go through the same pain.
Actually, we'll also talk about caregivers and the role they play in now dealing with this condition. So your pay bill number 6847877. Guys, you can just try and contribute, and at least as we're finishing, Dr. Patel, there's someone who wants to connect with you. They want to know where they can find you as well.
Okay, yeah, no, I am based here in Nairobi. I have my clinics at Doctors Park, and I am also at Third Park Hospital, which is an endometriosis multidisciplinary team center. So yeah, they could get me at any of the two places.
Thank you. Thank you so much for coming, guys. I wish we had more time to just continue this conversation. It was really impactful. Thank you, Senje. Thank you, Daktari. And remember to just keep on sending the feedback. All the by this zimekuja kwa wingi, and we'll get to read them also next week. We'll continue the conversation on endo. So stay tuned next week, same time, same place. My name is Zaitun Ali. This has been Health and Wellness. Until next time, see you later.